Good afternoon, everyone, and welcome. This is Doug Fish with the New York State Department of Health, and welcome to our webinar for the PPS's to give an update on the New York State Patient-Centered Medical Home Program. With us today, first will be Dr. Marcus Friedrich, who is Medical Director in our Office of Quality and Patient Safety, and he will give us updates on the New York State-specific PCMH model. And then Dr. Alda Osanaga from our Office of Health Insurance Programs, that is Medicaid, in the Division of Program Development and Management, will follow. So they will go sequentially, and then after that we will have the chat box open. You can type in questions as we go through, and we'll take questions at the end via the chat box. All lines are muted. This webinar is being recorded and then will be posted to the digital library. So without further ado, I'm going to turn it over currently to Dr. Marcus Friedrich in our Office of Quality and Patient Safety, and welcome, Marcus.
Yeah, thank you, Doug, and welcome, everybody. Thanks for joining in this afternoon. So we have a pretty tight agenda in front of us, but what I wanted you to get out of this webinar is really some information about this new New York State PCMH model. Under the rubric of alignment different models, we came to this model with our colleagues on the Medicaid side, and I just want to talk more details during the webinar about that. You will get some other information about the PCMH incentive program and the reimbursement and some of the changes that are coming down, and then hopefully we have some questions at the end that we can answer ourselves. So my name is Marcus Friedrich. I'm actually a primary care provider in the community here in Albany, and doing primary care in the HIV community. So I'm fairly familiar with the the pain and suffering that a lot of primary care providers are feeling right now, and therefore I think it's really good to stay updated, and I hope that this new program really that primary care providers can benefit from that. I always, when I start talking about primary care transformation, I always go back to this slide. This is the State Health Innovation Plan. This is how New York started around 2011, 2012, started thinking about not only primary care, but health care delivery in general. And you see these 5 pillars: access, integrating, care and address patient needs seamlessly, really to reduce the silos. The transparency, that is the middle pillar there, is a very big issue, giving transparency around cost and quality. This push to value-based payment is also like a big pillar, and then the promotion of population health and using our prevention agenda here in New York. What is not on the slide is this overarching goal until 2020 to reach 80% of patients, to care for 80% of the patient in what we call an advanced primary care setting. That includes models such as PCMH, but also this APC model that I will talk to you a little bit about in the coming slides. And then the other piece of the puzzle was also the 80% of having patients cared for and reimbursed in value-based payment arrangements. And this is a goal that Medicaid clearly has with the district side, and also a goal for us on the SIM side that we are trying to reach. I wanted just to compile a list of really high-level program highlights. These are the main CMS demonstration programs. There are others in the state. Just to give you a slight idea about DISRIP, and all of you guys are involved in DISRIP, so I'm not going to go into detail, but on the SIM side, it's a much smaller program with about $100 million that we received as a grant. We are using a different vehicle for transformation. On the DISRIP side, you have the PPSs. On the SIM APC side, you have these transformation agents or vendors that we are using that are paid for by the SIM grant to help these practice transform. And then you have these different models. On the left side, there's this NCQA PCMH model, and also some APC Gate 2 requirements sprinkled in. And then on the right side, on the SIM APC model, we try to stay within our own developed primary care model, because we thought that PCMH at that time when we developed this was not going far enough. But you see the different approaches. On the left, the Medicaid plans, and then on the right, like targeting more, a commercial multi-payer approach that includes other lines of business such as Medicare Advantage and so forth. But overall, like if you just take a step back, there were also similarities. But it is really confusing, and I know, speaking out of my own experience as a primary care provider, all these different, acronyms, DSRIP, there's this TCPI program, which is another CMI program, then ACRA and CPC Plus from the Medicare side, and really a very confusing landscape here in New York. And our overarching goal, not only from us, from the Office of Quality and Patient Safety, but also from our colleagues on the Medicaid side, is to reduce some of the confusion and really align the different approaches where possible, especially on the primary care side, and also supporting practices in their transformation effort. And all of you have been part of that on the PPS side, and we are certainly supporting them also with our SIM dollars around this. And, although it's confusing and although these are very different approaches, such as DSRIP and the SIM APC, there is also an incredible alignment if you just take a wider step back and looking at that. For example, the VBP approach. All of you are familiar with the Medicaid VBP roadmap. And in essence, this is similar to what we're using on the SIM APC side, like a commercial approach that very closely resembles, the roadmap. But there are differences, slightly differences, but overall, arching is that we want to go a little bit away from the fee-for-service reimbursement towards this value-based payment approach. And then primary care focus, DSRIP also thinks about improving care and access to care, same as on our SIM side. The population health approach is similar, and then the quality measurement, and we are using on the SIM APC side a standardized measure set, and the DSRIP side on their primary care value-based payment programs also have adopted that standardized measure set and just put a couple measures on top of that. But you see there is, if you just look through a wider lens, there's a remarkable, alignment already happening, and we just still want to continue in this approach for the state. There is health IT alignment, and some of you heard about this Shiny New York, which is this state health innovation network that New York built over the last couple of years, where on our DSRIP side, but also on the SIM APC side, where it's mandatory for practices to actually sign up for with the Shiny and get information out of the Shiny. This aligns with national activities and quality measurement and so forth. And there are really exciting, new approaches also on the Shiny. One of them I just want to mention briefly is the health IT-enabled quality measurement, meaning that in the future, we envision a time where nurses don't have to go into the practices, where we could take quality information out of these linked EMRs directly to provide, quality oversight and also your reporting requirements. There's also on the quality measurement side alignment already that exists between the VBP arrangements and APC, as I mentioned earlier, using the same measure methodology and approach, but also using the same cycle of updating the measures going forward. And that is already happening, and there is a group here at the state level really heavily involved with this. And then just to highlight the current program participation, you know that we have a Medicaid PCMH incentive program. There are currently 2,200 practices involved. There are currently 750 practices in the SIM APC program, and the number of physicians also varies, about 8,500 on the PCMH side and about 3,000 on the SIM APC side. The numbers have been growing very rapidly. As you know, there's the deadline for the PCMH practices under DSRIP, And so I assume there will be some leveling off over the next coming months, but if you compare them to a year and a half ago, they went up by about a quarter, which is a remarkable move. And then some practices and some of the providers are recognized in both programs. About 15% of our SIM APC practices are currently PCMH certified, which is also interesting. But overall, you know, one thing that was really missing with these different approaches, PCMH, APC, or CPC+, was like an aligned program around a common primary care transformation program to reduce the confusion, to make it easier for practices who are willing to transform and building capabilities to sign up with with one program going forward. And there was last year, I still remember around this time when I first got wind of the NCQA PCMH 2017, and they really did a 180-degree change compared to their PCMH 2014 model. They revamped their program and they came up with this improvements that they're calling, but in my mind is really that they actually went at it with a blank sheet and said, okay, how can we make this really more aligned with where the market is going and where other programs are going. So again, it supports continuous practice transformation instead of these milestones that you are familiar with on the APC side. They have these 3 checkpoints. You're not being left alone during these transformations until you get to the recognition level. They are helping you with these check-ins. And then after you got your recognition, there are these yearly check-ins to verify the continuous improvement. It improves the flexibility. They updated their whole documentation system. It's called QPass. It's a fully computerized system. You don't have to send in folders after folders of documents anymore. You can all upload them, and in real time the NCQA staff is actually verifying those information and giving you feedback. And last but not least, it adheres clearly to this Medicare MACRA and MIP standard, which is a program that is very fast approaching, and being able to align with that program is also very important. So they created a lot of good things, and by just looking at our program that we had, this Advanced Primary Care, and this new program, and this is just an example, we did a very in-depth crosswalk between this program, and there was already a 93–94% alignment just from face value. And we saw this as an encouraging sign to think about, you know, going forward. And we have this one question that I always raise: why would we create a distinct PCMH or New York State PCMH program? And the answer is that we still didn't think that the NCQA program in itself didn't go far enough. You know, New York State is very diverse. It has different areas, the urban areas, and then also rural areas. And there were certain areas where we felt, and I mean the SIM side and also the Medicaid side, where, you know, we wanted to put an emphasis on, and that is health IT, what I meant earlier with the connection to the Shiny. The behavior health integration was critical important, and most of you are working on projects on the district side on that. The rigorous care coordination, population health, and this potential for multi-payer support was also important for us. And therefore, we thought that even though they had a program in place, it was not going far enough, and that's why we thought about creating a New York State PCMH. The discussion would just probably end it there, but NCQA signaled very early on that they're willing to discuss this with New York State, and so we went into a long negotiation phase with them and thinking about how could this look to building these priorities for the New York State practices. The other question that always comes up: why would we even align with something like that? And I think I tried to show that on the ship, this acceleration towards delivering value and getting practices to be ready for value-based payment, but also being successful in value-based payment was incredibly important, not only for our side on the SIM side, but also I know on the district side. And then, of course, to simplify a very confusing and complicated landscape, and also the idea of aligning around one common practice transformation program was certainly something that resonated with all of us here in the department, and also with a lot of providers that we engaged in many stakeholder meetings going forward. And then now I want to go into a little bit more of the details, give you a little bit more background, why we did what we did, and where is it all originated from. So the program details is, again, going from, and you see here on the left, how NCQA designed the PCMH 2017 program, and then I try to compare that to what we designed this New York State PCMH program. And we, again, is not saying that we just sat in an ivory tower here in Albany coming up with a certain set of criteria. No, we actually went out and engaged stakeholders in the SIM statewide steering committee and other meetings that we had with the physician associations, including payers, consumers, provider organizations, that helps with that to come up with a certain set of criteria that would make this program New York specific, by also keeping the same standards as this NCQA PCMH program, and trying to improve the practice transformation. So just a couple, without going too much into detail, the idea was to move some of these core criteria that were identified, some of the electives that always are part of NCQA, using 12 of these electives that highlight kind of where we wanted to go as a state towards, and move them into core criteria that we would rebrand it and not call it NCQA PCMH 2017, but New York State PCMH 2017, somewhat like exclusively, because an alignment only makes sense if you all land at the same transformation model and the same recognition model. It doesn't make sense if there are similar models still out there not being used or being used here in New York. And then we wanted to keep this what we call state-funded transformation agents. This means that we use some of the SIM funding to help the practice to achieve this recognition, and that we wanted to continue that. And then also under this, what we call Medicaid support, this PCMH incentive program, to make sure that, we are continuing with that support of primary care practices. So this is how it looks like in general, and I was speaking to that a little bit earlier. PCMH 2017 had like 40 core elements and then a bunch of electives, and we moved some of these elective criteria, namely 12, into the core criteria by reducing at the same time what practices needed to do on the electives. So we didn't increase the level that practices had to do. We just shoved a couple of these core electives into this core requirement going forward. And again, these additional core criteria, and I have a slide, next slide on it too, they cover these places where we felt New York State put a lot of emphasis on the behavior health integration, health IT, VBP arrangement, and population health. And then instead of doing 25 additional credits on the elective side, because we already have 12 core electives that we moved over, for this New York State PCMH, the practice only have to earn 7 additional elective criteria, which is much less than in the original model. And then the continuation of the TA vendor capabilities, that was also important for us, at least in this model. These are the 12 core criteria, and out of these domains that I already mentioned, they go, and I just put the slide up for you as a reference, and also we certainly have the material for the 40 and now 52 core criteria that are required in this new program. But this is nothing new, and again, this was not developed just by the state alone. This was developed in conjunction with the payers and providers out there that felt that these were important criteria to be part of this program going forward. The transformation agents will continue to play an important role in this program, in this New York State PCMH program. There will be what we call the 3 check-ins, and this is really after working for 3 months on certain requirements that you can submit your paper and get it graded by NCQA and getting feedback from them immediately versus how it was in 2014, where you have to submit everything at the end and then you got a thumbs up or thumbs down. This is a more hands-on approach that you can get feedback right away if something is not right, and hopefully that will make it easier for the practices going forward. And again, the TAs are there free of charge for the practices. They are really set up from us to help the practices going through this stepwise improvement. And then after you are recognized, comes this, what they call the PCMH annual reporting, and we just adopted that. These are like yearly check-ins where you have to provide certain information to NCQA to keep your recognition current. These are, documentation. This could also mean, practice performance metrics that could be submitted around what we call like 6 categories. And NCQA is actually auditing, a selected group of practices every year if they actually provided this documentation. And this is probably one of the more important slides, which really shows, for most of you out there who are having different levels of recognition currently and how this will work out over the coming years. And I'm just starting like at the top with the new practices. They have to enroll in this New York State PCMH model, and then 1 year later in 2019 achieve the recognition, and then 1 year later in 2020 do the annual reporting going forward. The level 1 and 2 practices and the level 3 practices, they have kind of like a different approach. There are many practices expiring in 2018, and they have to do this, what they call the first New York State PCMH annual reporting that will give them automatically the New York State PCMH recognition. And then there are practices expiring a little bit later. Most of you who have transformed to PCMH have recently transformed to PCMH, so you are not expiring, but you're expiring in 2019 or 2020, and we wanted to make for those practices this first annual reporting and the recognition optional, because there might be a need for those practices to actually get the recognition a little bit earlier. And then this goes on like 2019 and 2020. Again, I'm not going to go into detail. Then there are these APC practices that are currently enrolled, and APC will stop exist starting April 1st, and everything will be converted to this New York State PCMH model. The APC practices, they will enroll in 2018. They will hopefully get their recognition in 2019, and then start this New York State PCMH annual reporting after that. And this is, another slide what I think is very important, and this talks about the cost of the transformation. And I'm very happy to report to you that we got approved from CMS, actually through the SIM grant, to pay for this recognition program going forward. So every practice that is currently PCMH level 3, will have the cost waived or paid for by New York State PCMH by the SIM grant, and all the APC practices will have the cost for New York State PCMH, the NCQA application costs and so forth, paid for by the SIM grant, and also the other levels and the new practices. The big caveat I put there in highlight down there, that the SIM grant funding will end in February 2020. And going back to the slide what I mentioned earlier, that's the reason why some of the practices who just recently got recognized at PCMH 2014 level 3 should take advantage of this funding mechanism through which we are funding this. And in practice, it will look like there will be codes for that you will submit with your application to NCQA, and you don't have to sign up for our SIM APC program because a lot of practices actually don't want transformation agents in their practice to help them. So they can submit a different code than practices actually who want the free help of these TA vendors, and they submit a code for getting not only practice transformation, but also this fee waive. But overall, this just recently got approved from CMS that we can use our SIM grant to push this program forward, helping practices to get this recognition, starting in April. This is, again, what I called about, or what I mentioned earlier. April 1st is the start date of this, and all these different recognition programs will fall into New York State PCMH. There will be no new recognition of PCMH 2014. There will be no new recognition of PCMH 2017. And for those practices, and there are very, very, very few practices who are already PCMH 2017, these practices in their first annual check-in will automatically get their New York State recognition if they fulfill the requirements for this New York State PCMH annual check-in. So why, and this is again up for every practice and for you as the PPS leadership, why should practices transform to New York State PCMH? And I try to highlight some of the issues in my previous slides, but again, the big question is really, is it helping my practices? Am I building capabilities to be successful in value-based payments or in the future that I see my practice going into? So Medicaid and the commercials are clearly going into this value-based payment direction, and being successful is really important, and that's why we feel that this program can really help you. Participating successfully in Medicare, this is another, about a third of, payment dollars, at least in New York State, is paid for under Medicare, and being successful under these MIPS requirements where you get automatic recognition once you are New York State PCMH is probably also very important. And then, of course, take advantage of the transformation fee that's paid for by the SIM grant, and I can guarantee you these grants will go away after 2020. So the earlier you can get, get into this program, it would be probably more advantageous for you. Then I want to just, and to wrap it up, I just have one more slide. I'll give you a little bit about the perspective of New York State DOH, and this includes, and I'm certainly not talking for the Medicaid side, but also for, where we're going as New York State overall. We are thinking very strongly about primary care and thinking strongly about primary care transformation. You saw the SHIP goals, and including access, integrating care, putting emphasis on transparency, but also the continued path towards VBP and population health are critical, important going forward. And this is not only, New York State, but as you saw earlier, also other commercial payers around this. We will continue to work with CMS on advancing care models. This is, as you know, DSRIP has expected life of about 2 years, and the SIM APC grant as well. There are already discussions between the Department of Health and CMS to think about, what comes after that. And I'm pretty sure that, primary care will be somewhat included in the thinking. And the better you are set up as a practice for this challenging world out there that comes after DSRIP and after SIM, the better off you probably are. And this is it for me. And thank you for your time, and thank you for having me here. And I will hand it over to Dr. Osunaga, who will talk you through the Medicaid PCMH incentive changes.
Thanks, Marcus. And we'll take questions for both parts of the presentation after I have about 3 slides. So many, if not all of you, have seen our January Medicaid update article, which outlined proposed changes to the PCMH incentive program. And the changes are in response to the proposed executive budget for the upcoming state fiscal year, and that budget proposes to cap funding for the PCMH incentive program for the upcoming fiscal year and the out fiscal year. And the proposed cap amount does not cover the cost to continue our PCMH incentive rates at their current levels. So rates will need to be adjusted. And you'll see in the January Medicaid update that an adjustment comes pretty soon. And I just wanted to point out that the reason, oh, sorry, can you advance? I should have advanced. Sorry, everybody. I'm talking to a slide that is not posted. The reason that we are making a change before July 2018 has to do just with a payment lag. And in order to, a payment lag from when the department gives the money to the plans mostly to pay out the incentive, and there's a payment lag there. And in order to affect a change for the upcoming state fiscal year, we need to make changes prior to July 2018. So the changes, this chart outlines the changes that we are proposing, and this is what we published in our January Medicaid update. These changes would be effective May 1st. And one part of this is that we would stop on both the Medicaid managed care plan side and the fee-for-service side to pay for PCMH providers who are certified at 2014 level 2. They would no longer get the incentive, and that would be a permanent change. As for the 2014 level 3 providers and anyone higher than that, so we just heard about PCMH 2017, we're proposing the New York State PCMH, and we've been messaging this for APC, current APC providers, that we are still waiting federal approval for this. They are the ones that currently get our highest level of PCMH incentive, and that would, for the PMPM, that would go from $7.50 to $2. And the fee-for-service add-on payment would remain the same. And those changes are for the months of May and June. Come July 2018, so starting July 1st, 2018, everything we do from there really affects not the state fiscal year that's upcoming, but the next one, so the state fiscal year that begins in April of 2019. And so on or after that date, we need to make another change. We don't want to keep providers at this $2 level. We'd like to be able to increase that current rate that we're proposing for $2. So the other thing that we'd like to do is also tie the incentive to value-based payment contracting. So proposals assume, and we've gotten some questions about this, proposals would assume, like I say before, providers have PCMH certification at NCQA 2014 level 3 or higher, that providers have a Medicaid VBP contract. It has to be at least one Medicaid VBP contract at level 1 or higher, and providers would only need one Medicaid VBP contract with at least one of the plans that they contract with. If you contract with 5 plans, we don't expect that you have 5 Medicaid VBP contracts with them, but at least one with one of the plans. And we're looking into seeing if we can also tie the fee-for-service incentive payment to VBP contracting for those providers who participate in both fee-for-service and Medicaid managed care. If you don't participate in Medicaid managed care, if you're a fee-for-service only provider, we would not tie an incentive. You're at least on the fee-for-service side to VBP contracting. We have not finalized yet what our current policy would be. We are still discussing this, and we are also waiting for the final budget. It has not been finalized yet. So as soon as we hear more and have more information, we will be issuing guidance materials for everybody. But that's where we are right now. And that's the end of my slides. So we are now ready for questions. If you have questions, you can type them into the Q&A box, and we already have some, so we'll start.
Thank you, Alda. Thank you, Marcus. And so we'll start with the questions here. We do have quite a few. So the first is, for the New York State PCMH model, how many additional credits are needed for that model? Is it 6 credits or 7 credits?
The issue is that it depends on one of these core requirements. One of the core requirements is being in a VBP contract, and you get different points for different types of VBP contracts. You get 1 point if you have just an upside only, and you get 2 points if you have an upside and a downside only. And based on that, that's why we can never say, do you need 6 credits or 7 credits? It depends on this, on one of these core requirements where you get a different amount of points for it.
Thank you. Do practices get the same level of TA support in terms of duration, regardless of current status? Some practices are APC Gate 2 and or PCMH 2014 recognized, while others may have no prior level of recognition.
Yeah, the TA support is really geared towards what the starting point is of your practice. And that's why there is an extensive questionnaire and a discussion before that where you actually start in this journey towards transformation. So practices who are already PCMH 2014 level 3, you can imagine they are probably very well equipped to do that little step towards New York State PCMH. But imagine a smaller practice, a rural practice that has not engaged in any transformation. They need to start from really the beginning. And so the TA vendor approach or contract probably is prolonged in those practices versus, these high-level practices. And again, I want to make that very clear. Not every PCMH practices need to go that TA vendor route. It is certainly open for everybody to sign up for that. But if the practice says, I'm very fine doing my own thing, they can just sign up and still get, the application fees paid for under the SIM grant without being part of this TA vendor construct.
Got it. So the TA support not required, but they can still get the assistance. Okay. And I think you touched on this. This question came in before you actually got to the slide. But what about practices with PCMH 2017 recognition?
Yeah, and these practices are already certified under this new model. They have to then in the first annual, check-in, they have to just fulfill the requirements that they're still lacking. And you saw this one slide with the 12 core requirements that we took from the elective requirements.
Yes.
So those core requirements, they need to fulfill those 12 core requirements to get that New York State PCMH recognition model.
Okay. Next question. How does one get the SIM grant funding if the practice is 2014 PCMH NCQA level 3 already? Where do we get the code?
The materials will be published very shortly. It's a joint production between NCQA and the Department of Health, where you will get the code. It all starts April 1st, 2018, in the next 2 weeks. You also can contact the TA vendors, and I didn't put a slide up there. 16 TA vendors across the state, and there is certainly on New York State's DOH website under SIM grant. There is a slide which shows all the 16 TA vendors and where they're located.
Sending the link to Doug and Alda right now, and you can send that out.
Great. Yeah, another question here. Who's the TA vendor for the Bronx, et cetera? So we'll send that out.
Right. And the state is split up into 8 DFF regions, and that's how TAs were designated across New York State through 2 rounds of, an RFP process.
There is not one area in the state which is not covered by a TA.
Correct. And there's multiple TAs in each of those different regions as well.
Okay.
So you have the choice.
Thank you, Scott.
It's always good to have a choice.
Always good, right?
Yeah.
So next question. If our practice is currently 2014 NCQA PCMH level 3 and scheduled for renewal in April of this year, 2018, will we be able to complete the New York State PCMH program?
Yeah, well, we start in April 2018. The NCQA has built already the New York State QPAS program. So I think there's more to the question if you scroll down a little bit.
Looks like there. Yeah. And if they're not able to meet some of the additional 12 core items required for New York State PCMH. How do we submit? Would there be an extension?
Yeah, it's a good question, and I have to take that back to NCQA. This is a very specific case. We looked at actually numbers when they're expiring, and that there were not many practices expiring now in April, but I hope by the 1st of April everything will be ready, so you can, sign up in QPass using these codes that we will provide to all of you, and then do these requirements and get the New York State PCMH recognition.
Right, and I would suggest to not holding off on reaching out to NCQA about an extension. They have been very open to individual cases and practices that are kind of in that range of expiring or their recognition lapsing over the next few months. Reach out to NCQA. They have a lot of options as far as 60-day extensions, and then there is it's going to be published on the NCQA website, the pathways document for all those different types of practices. But we have worked very closely with NCQA, and that's one of the things that we're very focused on, is trying to make sure that practices don't have a lapse in their recognition for the 2014 Level 3. And one thing that I will say that NCQA has pushed back a little bit on us is that all of the practices that are lapsing a year in advance, so it would have been April of 2017, they would have been notified that they are coming up within the year on their recognition lapsing in April of 2018, and kind of what the plan should have been for those practices. And so we understand that there are some practices that maybe didn't act on that, when they received that notification about a year ago. But NCQA has been very willing to work with practices on extensions and kind of that accelerated pathway that Marcus had talked about for 2014 Level 3 practices, and also some of those, the few practices that are actually 2017 recognized already as well.
Great. Thank you. Again, that was Scott Rader. Has any thought been given to doing something similar with the patient-centered specialty practice program for specialty practices?
We wanted to target the primary care arena first before we look into other programs. So
okay,
it's certainly something that we've discussed with CMMI as we talk about the last couple of years of our grant. Obviously, this SIM grant has been focused on primary care, but the possibility after 2020 of additional rounds of CMMI funding for state innovation test awards is something that we've talked with them about. But
okay,
what about CPC plus practices and potential?
This is another interesting question, and we are in our APC, Advanced Primary Care model, we excluded CPC plus practices, but there is a need now for renewing that discussion around New York State PCMH, and we are currently in discussion with CMS around those practices. One of the big problems that we are facing is, a big no-no from CMS about the duplication of funding, and this goes back to a discussion that we had with the DSRIP program. So if we are actually reaching out and transforming practices using CMS SIM funds, CPC Plus cannot do the same thing, or vice versa, and we got to be very careful. So there are ongoing discussions about CPC Plus practices right now. There are ways of doing this, but we have not finalized that in overall.
Yeah, and this is Scott Ritter again. I just wanted to mention, as Marcus said, we are having ongoing conversations with CMS, with our project officers at CMMI, on how we could possibly include the CPC plus practices. As Marcus said, one of the things that we're working on right now is putting together a crosswalk between CPC plus and what that transformation looks like, and what what support practices are receiving through CPC plus, and how that's going to look crosswalk to our New York State PCMH model. So we're working with NCQA and, as we mentioned, CMS on a crosswalk, just to make sure that anything that's funded through CPC Plus, or that's supported by the federal government through CPC Plus, would not be duplicated with our New York State PCMH TA services. So there will be a pathway. We just have to, it's going to take some time for us to work with CMS on when we can bring in those CPC Plus practices to also receive TA services and work through New York State PCMH transformation.
Thank you. So next question is in terms of how does current PCMH support that people get through the incentives, the practices get through the incentive to support continued priorities be sustained if the PMPM is cut to $2?
Right. And we know that this is a large cut, and that this cut, we tried to give as much advance notice that we could, but we know that this is sudden, and this was unexpected, and that this was large. Hopefully, we are working really hard to see how we can maximize the amount of dollars that we have come July 1st to make sure that you can continue to provide the care that you are ready to provide to our Medicaid patients. We've gotten a lot of feedback, we've heard it, and we are really trying to balance out what we can do come July 2018, and we've got a few proposals, and we're just trying to see which is the best way to maximize what we have, cover as many people as we can, and make it so that it is more than $2. It will be more than $2. We just haven't finalized exactly how it's going to be split up.
Just as a reminder, that $2 is just for May and June,
right?
And then it will increase to some level. Thank you, Hulda. For practices that have just met the 2014 NCQA PCMH Level 3 for the district deadline, what do they expect in terms of changes for New York State PCMH programs? Are these practices not able to receive the Medicaid payment increases until they transition to New York State PCMH?
So if you are currently 2014 Level 3 certified, you will continue to receive the Medicaid PCMH incentive. We are not asking that providers move automatically into New York State PCMH. If your certification expires, that will be what is open to you. If you would like to move from 2014 Level 3 to New York State PCMH, you can do that, but we are not requiring movement from 2014 Level 3 into New York State PCMH.
Okay. Next question. Can you speak to what VBP Level 1 means? What is Level 1 specifically? So if, this is Doug, if we're talking about the Medicaid Managed Care VBP program for New York State Medicaid, Level 1 is an upside-only type of arrangement that is still a transactional arrangement where services are rendered by providers, fees are paid by managed care, and at the end of the year, there's a reconciliation against a target budget that is set at the beginning of the year. That target budget is agreed upon between the provider organization, the VBP contractor, and the managed care organization. That target budget takes into account the last 3 years' worth of historical claims. There's a performance adjustment for high-performing and high-efficiency providers. There's a growth trend adjustment and other elements that factor into the target budget. There's also a risk adjustment, a 3M risk adjustment for the population-based arrangements, and for the episode-based arrangements is the Alterum Prometheus Rupert. So again, Level 1 is a upside only, meaning there's no downside risk to the practice, even if that practice comes in over the target budget that's set at the beginning of the year.
I was just going to add on to, it kind of goes back to Marcus's point when we talk about value-based payment contracting for the New York State PCMH. Level 1 that Doug just mentioned, that's what we're considering, you know, achieving that 1 credit, and then upside and downside would be the 2, would give you the 2 credits. But Level 1 is, as Doug mentioned, just that upside only.
Right. Level 2 and Level 3 begin to take on risk. A Level 2 risk in New York State VBP Medicaid would still be a target budget that's set at the beginning of the year and a retrospective year-end reconciliation against that target budget. But if you were over that budget and had losses, some of those losses would need to be made up in the next year's payments. And Level 3 is the prospective capitated per member per month type of arrangement where practices are getting the dollars up front. Next question, is there a crosswalk available for PCMH Level 3 2014 to the newest edition 2017?
Yes, there is, and NCQA will publish that very shortly on their website.
Would you clarify that the payment changes starting May 2018 will last through March 31, 2019?
Right, so the payment changes for May 2018 are for May and June. We have not yet figured out what it'll be for July 1st. It will go up.
Thank you. Next question. Do we know the codes for NCQA to cover the application costs?
No, we don't yet. That will be published very shortly on DOH and on NCQA's website.
Next question. We're currently pursuing 2017 PCMH recognition paying a private consultant. Would we still be able to access SIM grants for our transformation?
The answer is after April 1st, you can sign up with a TA vendor and receive the SIM grant or receive the TA vendor support in your practice. That's correct.
But only going towards New York State PCMH,
of
right?
Course.
Not for 2017.
Can you speak up, Scott?
Yeah, I was just saying, so the SIM grant funding would have to be for working towards New York State PCMH.
Yeah.
And so if you're already working with a private consultant on the 2017, you could certainly choose to continue working towards 2017 and then make the decision if you wanted to pursue New York State PCMH. But for SIM-funded TA services, it's only for New York State PCMH.
Next question. To obtain enhanced reimbursements, does the VBP contract level 1 or higher have to be between the practice and the Medicaid managed care plan? For instance, a practice can get involved in a Medicaid VBP arrangement with another entity, such as an IPA.
Right, and this is something that we are still discussing and figuring out process-wise and operationally how this will occur. So we'll get back with the answers to that.
Next, if a practice is PCMH Level 2 under 2014, what are the next steps to transform to New York State PCMH 2017 and the TA support available? Is there both a DSRIP incentive and a SIM incentive as well?
So the answer is that there is, after April 1st, there is for this PCMH Level 2 practices, there is availability of TA support towards this New York State PCMH 2017 goal. And there is also the ability to receive this PCMH incentive program from the payment side, because these are two different things.
Right.
This is not, you know, there is what we call the PCMH incentive program, and then there's the TA vendor support, and these are like two separate things. They're not together in one program.
Right, and I'm just going to add, if you are getting DSRIP support to do transformation, you can't get both DSRIP support and SIM support to do the same type transformation. So I'm not sure if that's what the question was about DSRIP incentive. I'm not sure if that also means DSRIP money for TA support.
And also the practices, one of the requirements for the DSRIP program is the deadline of March 31, 2018 to become NCQA 2014 Level 3 certified. But that does not mean that practices couldn't work with their PPS to support practices for ongoing transition and transformation. If all current practices opt to participate in New York State PCMH, are we confident there are sufficient SIM funds to pay for all NCQA fees up to February 2020?
Yes.
Excellent.
We have one right above that, Doug.
To support New York State primary care practice transformation, New York State PCMH 2017, when does the state plan to extend the opportunity to other qualified technical assistants, for example, opening a new RFA?
We had already 2 RFAs. In the first round, there were 8 vendors. In the second round was another 8 vendors. We currently have capacity to, you know, cover up to, you know, 2,500 practices. So we don't see a need right now for opening up another RFP for TA vendor assistance.
Next question, just to confirm, after April 1, 2018, New York State practices currently recognized under NCQA 2014 must participate in NCQA PCMH New York State specific program. That is to say that the national PCMH NCQA recognition will no longer be available.
Well, I wouldn't call, nobody must, but if you want to renew your practice recognition, you certainly only can do it under New York State PCMH.
Next question, is there a capacity limit to what TA vendors can handle? Is this a first come, first serve situation to get technical assistance?
It's a good question, but all our TA vendors still have capacity, and I think we will approach that issue once there are capacity issues that we are identifying, and there's currently, in all region, there are capacity issues.
For practices that are currently NCQA recognized under 2014 Level 3, will they be eligible for the TA through SIM funding?
Yes.
Next, we post a webinar online. Will it be available? So yes, as we mentioned at the beginning, this webinar is being recorded. It'll be posted to the digital library, and we can also send out a PDF of the slides with the Monday email blast that goes out to the performing provider systems. Next, we have an FQHC with several school-based sites and are looking into PCMH certification. How does this affect school-based patient-centered medical homes?
Well, so we know that there are some school-based medical centers that are actually PCMH recognized, and then there are other school-based health centers that are looking into getting certification through a school-based specific medical home program for NCQA. So this question, so I think that this is referring to if you are a school-based health home, medical center, and you have PCMH certification, not in the other program, would they also have to do the New York State PCMH? I would think that the answer to that would be yes.
That is the answer. Although I'm not very familiar with that school-based program. I know that there were some discussions on this side if school-based programs will get reimbursed under the PCMH incentive program, and the answer is no.
No.
And we have to also look at specifics of these programs if they can use SIM fund. And for now, I think the answer is no, because they don't qualify for what we consider primary care.
Next question. How can you confirm if an arrangement is considered a VBP Level 1? We have practices that participate in incentive programs through our IPA and want to know if these will qualify as a Level 1 arrangement or not. Some of these questions are fairly specific and get fairly technical.
But I mean, we can say, so we are asking the plans, and the plans know exactly if you are in a VBP arrangement and at what level they are. So based on the information that we're getting from the plans, we will then, aggregate that level of information here at the state and then make a decision about if that fulfills the requirement, and then therefore issue the payment based on that.
Right, and that's how we're doing it for the PCMH incentive program. In order to check the box for the New York State PCMH, there's a criteria that NCQA have to verify that.
Next, how do we ensure our organizations and providers that after they do this transformation work, they will be paid as promised when current funding has been cut starting in May? We have lost credibility with some of our teams.
So, so we know that there has to be cuts. We know that the PCMH incentive is out in the January Medicaid update. When we have changes to that, we will post them again in a policy effective in our Medicaid update. And we're hoping to get that out as soon as we can. Like I said, this was part of the proposed executive budget, and the budget is currently being negotiated. And I don't have any updates on that, but we'll have to see where that goes. And as soon as we know what our final numbers are, we will publish this out in a policy. In the Medicaid updates, and you guys will make sure that everybody has a copy of that too.
Well, thank you both very much. Thank you, Scott, for your responses here. We're out of time. We got to, I would say, 85–90% of the questions. There were a few more left. Some are kind of repetitive questions, I really appreciate your questions. Again, this will be posted to the digital library. That takes a few days, and we'll send out a PDF of the slides to the PPSs. Thank you very much for your participation today, and have a good day.